Hello, my dear friends. Let us discuss the motility disorders of the esophagus today. So, how does the motility disorders present? These motility disorders present with dysphagia, odynophagia, vomiting, regurgitation, and non-cardiac chest pain. You evaluate the chest pain for everything, but it is not a cardiac chest pain. And so, these are the different clinical presentations. It is similar to the esophageal cancer, but the patient will be in a younger age group, not an old age group patient. So the functional anatomy of esophagus. So we have the upper esophageal sphincter, the lower esophageal sphincter, and in the body of the esophagus, there will be inner muscular layer and the outer longitudinal layer. So there is an upper esophageal sphincter, lower esophageal sphincter, and the body with an inner circular layer and outer longitudinal layer. Motility disorders of esophagus can be classified as primary motility disorders and secondary motility disorders. Primary motility disorders are those disorders in which the problem is in the esophagus itself, whereas secondary motility disorders come as a result of a systemic disease like Chagas disease by Trypanosoma cruzi, or even diabetes mellitus, or neurological disorders, with all these affecting the peristalsis of the esophagus. All these are the secondary disorders. Example include scleroderma, connective tissue disorders, chronic idiopathic intestinal pseudo obstruction, and neuromuscular disorders. Now, how will we approach these motility disorders of the esophagus? In our 12th standard and in our younger age group, we have only the light microscope, and we only learn about the cell in how we see it in the light microscope. So we only had the cell wall and the nucleus. Whereas as we advanced into medicine, we understood how the cell appear in the electron microscope, and it is not only the cell wall and nucleus, but there are a lot of organelles inside the cell. Exactly the same thing happened with the esophageal motility disorders. So initially, the only thing to learn, understand the esophagus was barium swallow. You drink barium and you take an X-ray. The barium swallow was initially the only thing. Then came the endoscopic evaluation. And on a later stage came the esophageal manometry, and the esophageal manometer has progressed through time into high resolution esophageal manometry. Okay, so let us understand the esophageal disorders in how it was perceived in different time periods. So initially there was only anatomical studies like barium and endoscope. So first, one of the first esophageal disorder to be identified is Achalasia Cardia. Achalasia Cardia, you can see the lower esophageal sphincter does not relax properly, and the body of the lower esophageal sphincter does not relax. So that is, it causes a functional obstruction in the esophagus. So the classical appearance is a bird beak appearance. The bird beak appearance. Then another disorder which was discovered, that it was diffuse esophageal spasm. The classical appearance of the diffuse esophageal spasm is like this. It is in the endoscopy also an appearance like this was visualized, and it is called a corkscrew appearance. We can see the corkscrew, the wine corkscrew appearance of the esophagus. So these were the investigations. These were the disorders of motility which was detected before the advent of our classical manometry. So then came manometry. The initial manometers were only there were 4 or 5 sensors in the initial manometers. But the newer high resolution manometers have 36 sensors, and it can take the pressure from all the directions in the esophagus. So these are the different types of manometry. The manometry has evolved over a period of time in the number of sensors and from the directions which the sensor can take the pressure. So let us now try to understand the primary esophageal motility disorder. In the earlier period, when there was only barium study, it was only achalasia and diffuse esophageal spasm. But when manometry came into the picture, Three more disorders was added into it. They are the Nutcracker Esophagus, hypertensive lower esophageal sphincter, and non-specific esophageal motility dysfunction or disorders. So let us try to understand this. So what did it show in the what does the primitive manometry show? So this is the manometric picture, and this is the upper esophageal sphincter. When when the swallow comes, the upper esophageal sphincter pressure decreases. That is, the upper esophageal sphincter relaxes, and the swallow progress through the esophagus. So these are the different plots. These are the different lines where each pressure sensor is kept. So when the peristalsis goes down the esophagus, when the peristaltic wave goes down the esophagus, a pressure wave is plotted. So that is the normal movement of the peristalsis down the esophagus. So this is the time, and it is the norm, and this is the length of the esophagus. Along the length of the esophagus, the peristalsis moves. Now comes the lower esophageal sphincter, the pressure point in the lower esophageal sphincter. What happens when the food enters the esophagus? The lower esophageal sphincter starts relaxing. When the food enters the esophagus, the lower esophageal sphincter starts relaxing. The relaxation is maintained like that, and then once the peristaltic wave goes, it comes back into the resting pressure. So these are the different pressure curves which was detected in the normal esophageal manometry. Now, coming to Achalasia Cardia. So how did the manometry understood Achalasia Cardia? When manometry came, we understood one more thing in Achalasia Cardia. We understood that the lower esophageal sphincter is not relaxing. Okay, its pressure is always high. There is no relaxation when the food enters the esophagus. And also we understood that there is no peristalsis in the esophagus. So it is not only a problem of lower esophageal sphincter, it is also a problem of the esophageal body musculature. So two components for Achalasia Cardia: inability of the lower esophageal sphincter to relax, and there is no peristalsis in the esophageal body. So then comes diffuse esophageal spasm. How does diffuse esophageal spasm show in esophageal manometry? We can see that the lower esophageal sphincter is relaxing well. Okay, no problem there. And there is normal peristalsis. Okay, there is normal peristaltic wave. That is also fine. What is the problem? There will be some contractions in the esophagus here and there. There will be some non-peristaltic contractions in the esophagus, giving this classical corkscrew appearance of diffuse esophageal spasm. Now, next thing which was found was Nutcracker esophagus. Nutcracker means the name Nutcracker because the contractions of esophagus are very powerful. So like a nutcracker, the contractions of the esophagus are very powerful. That is the peristaltic wave. It is a problem in the esophageal body. We can see the amplitude of the peristaltic contractions are very high. This is classically seen in Nutcracker esophagus. Now coming to hypertensive lower esophageal sphincter. This is a new disorder. Again, another one, Nutcracker, hypertensive LES, and non-specific esophageal motility disorders. These are the new ones found by esophageal manometry. In hypertensive lower esophageal sphincter, the lower esophageal sphincter relaxes, but it is not completely relaxing. But the esophageal body is okay. Esophageal body, there is no problem. The peristalsis is normal. So this is the hypertensive lower esophageal sphincter in manometry. Next came non-specific esophageal motility. Non-specific esophageal motility disorders can occur as a primary esophageal. All the before ones are primary esophageal motility disorders. Non-specific esophageal motility disorders can be primary, or it can be a secondary motility disorder also. Secondary disorder due to systemic problems. So non-specific esophageal motility disorder, the amplitude of the peristalsis is not good enough. There are many ineffective peristaltic movement. So these are the 5 disorders which are found out by our manometer. Achalasia Cardia and diffuse esophageal spasm was there from the time of barium. Nutcracker esophagus, hypertensive lower esophageal sphincter, and non-specific esophageal motility dysfunction was found by our normal manometer. Now time has progressed, our manometer has improved. So what happens? Instead of the 4 or 5 sensors, we have 36 sensors, and the sensors are taking information from all walls around the esophagus. So that is high resolution manometry, and as a result, our line drawing has changed into a color picture. Okay, so now we have to understand color picture. How will we understand the color picture? In the side they have given a line drawing, but how will we understand the color picture? Okay, for that we can see here that there is the pressure is shown. The lower pressure is blue and the higher pressure is red. The esophageal body will be in the lower pressure area. Okay, so esophageal body will generally be white. Upper esophageal sphincter, it is a high pressure area, high pressure zone. Lower esophageal sphincter is a high pressure zone, but not that much as upper esophageal sphincter. And the upper esophageal sphincter will relax when the food enters, and the lower esophageal sphincter will also relax when the food enters the esophagus. So these are the, just let me just show the 5 sensors here and how the and this is how the, instead of 5 there will be 36 in high resolution manometry. So what will happen in a pressure wave? How will the pressure wave be recorded? This is the peristalsis. Okay, this is a peristaltic wave. How is it recorded? You see, this will be recorded in something like that. When the amplitude of the pressure, when the pressure rises, the blue becomes green, again rises, it becomes yellow, again rises, it becomes red. And when it goes down, again it becomes yellow. When it goes down, again it becomes green, and then it comes to the normal blue color. So the peristaltic wave will appear in this color in esophageal manometry. So the peristaltic wave will be going down from the upper esophageal sphincter to lower esophageal sphincter. With this understanding, let us see that picture once. So this is a normal esophageal sphincter. This is the upper esophageal sphincter, and there is a relaxation of the upper esophageal sphincter is a high pressure zone. There is a relaxation when the food enters. That is this blue point corresponding this. And when the this is a lower esophageal sphincter. Okay, this green color is a lower esophageal sphincter here, high pressure zone. And it also relaxes when the food enters. It starts relaxing. And this is the pressure sensor. The lower blue, higher is red. When the peristaltic wave goes down like this, it appears like this. See, the peristaltic wave goes down like this, it will appear like this. The peristaltic wave from the proximal esophagus will go down like this. So it moves as the time increases. This is the length of esophagus in centimeter. So it goes down the length of the esophagus as the time progresses. So the peristaltic wave goes down the length of the esophagus as the time progresses. That is a normal esophagogram. Okay. And the resting pressure of the esophagus is blue color. That is the lowermost pressure in the esophageal body. Now, that is the time and length of esophagus. So, with this, our number 5 has increased in numbers. Into this, there were only 5 esophageal motility disorders when it was a simple manometry. Now, the Chicago classification, with the advent of high resolution manometry, a new classification has come. Now, Achalasia Cardia and esophagogastric junction obstruction. The Achalasia Cardia has become itself 4. It become type 1, type 2, type 3, and esophagogastric junction obstruction or hypertensive LES. Achalasia itself became 4. Major disorders of peristalsis, which include absent contractility, diffuse esophageal spasm, and hypercontractile esophagus. And then there is no obstruction in the esophagogastric junction in case of the major disorders of peristalsis. It is the problem with the body of the esophagus and not with the sphincter. And minor disorders of peristalsis, the sphincter is okay. The body, there are no major disorders, only some ineffective esophageal motility disorders. So let us understand through the pictures how are these motility disorders. First, we will discuss the major disorders of peristalsis, which include absent contractility, distal esophageal spasm, and hypercontractile esophagus. You are seeing a lot of numbers here. I am not discussing it at this point because it will, for for undergraduate level, it is not required. So I will be basically discussing on the images rather than the basically trying to interpret how to interpret the images rather than the numbers. So this is absent contractility. Here, what all are we seeing? We can see that the upper esophageal sphincter is normal, and when the food enters, it relaxes. The lower esophageal sphincter, there is also relaxation. But in the esophageal body, there is no contractility at all. Okay. So there is no contractility in the esophageal body. There is no peristaltic movement of the waves when we give the patient to, when we give swallows to the patient, when we give water to the patient, there is no peristaltic movement in the esophageal body. So that is absent contractility. Now, coming to our Nutcracker esophagus. Okay, the Nutcracker esophagus, a new name is given. It is called the Hypercontractile esophagus. It is named as Hypercontractile esophagus. Here what happens is that we know that the wave is very high. Okay, the pressure of the wave is high in Nutcracker esophagus. So what we do is we can see instead of the red, blue, green pressure wave going, since the amplitude is very high, everything is red. So that is the hypercontractile esophagus or Nutcracker esophagus. Next is the diffuse esophageal spasm. In diffuse esophageal spasm, we have the normal peristaltic wave and some other non-peristaltic contractions. Will we see in that this is the normal esophageal peristalsis. This is the normal peristalsis we are seeing, and the peristaltic wave is going down like that. And there is one wave when stops, another wave will start. In diffuse esophageal spasm, during the period of one wave itself, another contraction in the esophagus starts. So the contractions will be closer together, and it will be of higher amplitude, no more than higher amplitude. So this is the picture of diffuse esophageal spasm. Or why it is written as distal esophageal spasm? Because in the newer classification, it is renamed to distal esophageal spasm because this feature is more seen in the distal part of the esophagus. In Chicago classification, it is termed as distal esophageal spasm. Now coming that is regarding the major disorders of peristalsis: absent contractility, distal esophageal spasm, and hypercontractile esophagus or jackhammer esophagus. Now coming to the minor disorders of esophagus. They include ineffective esophageal motility and fragmented peristalsis. It was earlier called the non-specific esophageal motility. But once the manometer came, we could clearly see what is happening, and we understood that there are two components in that. One is ineffective esophageal motility, and next is fragmented peristalsis. What is the difference? Ineffective esophageal motility, the pressure of the peristaltic wave is very slow. Okay, so the pressure over the peristaltic wave is very low. There is no normal. The peristalsis is there, but the pressure is low. That is ineffective esophageal motility. In case of fragmented peristalsis, what happened? There is a break in the peristalsis. There is a break in the peristaltic wave. We can see there is a break in the peristaltic wave. There is no peristalsis in between. So that is called fragmented peristalsis. Now let us come to achalasia. So how will we see achalasia in esophageal manometry? And they have classified it as type 2, type 1, type 2, type 3, and a hypertensive LES. They have renamed and put a new name. So what will we do? Let us try to understand Achalasia Cardia. So we know that the lower esophageal sphincter is on a higher pressure and the esophageal body is not contracting. No normal peristalsis in the esophageal body. So your attention should be more here to understand this. So coming to type 1 achalasia. In type 1 achalasia, we can see that the lower esophageal sphincter, there is no peristalsis. In esophageal body, that there is no peristalsis. And the lower esophageal sphincter is not relaxing. So no peristalsis, everything is blue. And the lower esophageal sphincter is not relaxing. Now, that is type 1 achalasia. The picture is clear. Now coming to type 2 achalasia. Type 2 achalasia, we can also see that the lower esophageal sphincter is not relaxing, and we are not seeing any classical peristaltic wave. Then what is the problem? We have, instead of the blue, we are seeing everything as green. Why? That is because there is something which is happening in the esophagus, and the pressure is rising in the esophagus. The upper esophageal sphincter is closed here, the lower esophageal sphincter is closed here, and something is happening in the esophagus which is increasing the pressure in the esophagus. That is, pressurization of esophagus is happening. Why is it that? Because of the, here the longitudinal muscle works. Okay, because the longitudinal muscle works, there will be, the esophagus will be contract. When the longitudinal muscle works, the esophagus will get shortened like this. The esophagus will get shortened like this. Due to the shortening of the esophagus, the pressure inside the esophagus will increase, which will appear as this green color here. That is the classical feature of type 2 achalasia. Now let us see type 3 achalasia, which is also called type 3. The type 3 achalasia is also called spastic achalasia. Here again we can see there is no lower esophageal sphincter is not relaxing, and there is no normal appearing peristalsis there. Then what is abnormal? We can see everything is blue here. Not too much pressurization pan-esophagally, but there is a pressure zone in a point in the esophagus. Why is it happening? It is happening because here the problem maker is the circular muscle. A segment of the esophagus get contracted. A non-peristaltic contraction happens in some segments of the esophagus. So that is happening in the spastic achalasia or type 3 achalasia. Now coming to the hypertensive, hypertensive lower esophageal sphincter. What is happening in hypertensive LES? Here what happens is the lower esophageal sphincter is not relaxing. Now they have renamed it as esophago gastric junction outflow obstruction. There is normal peristalsis, there is esophago gastric outflow obstruction. And it is also considered as achalasia in evolution. Some of these patients will later progress on to the classical Achalasia Cardia. Okay. How will this esophagogastric outflow obstruction appear in the esophagogram, in the manometry? Here we can see that there is normal peristalsis here. The lower esophageal sphincter is not relaxing. There is normal peristalsis, but the lower esophageal sphincter is not properly relaxing. So that is esophagogastric outflow obstruction. Now, regarding the treatment, the Chicago classification has come nearby, and the treatment of esophagus is generally based on the earlier classification. The other treatment is actually evolving, especially in the third world countries. So how will we manage this? First, we will learn about the Achalasia Cardia. Achalasia Cardia, lower esophageal sphincter is not relaxing. So somehow we have to relax or disrupt the lower esophageal sphincter. So nitrates, calcium channel blockers can be given as medical management to relax the lower esophageal sphincter. Botulinum toxin injection can be given to the lower esophageal sphincter there, and it relaxes the lower esophageal sphincter. Heller's cardiomyotomy. Instead of relaxing, we can cut that lower esophageal sphincter and the mucosa will protrude out. Mucosa is not cut, only the circular and longitudinal muscle layer, the lower esophageal sphincter is cut. So it gets relaxed. So Heller's cardiomyotomy. And finally, instead of cutting it like that, we can disrupt it by putting inside a balloon dilatation. By putting a balloon and inflating the balloon, we can disrupt the lower esophageal sphincter, again causing loosening of the lower esophageal sphincter. That is the treatment of Achalasia Cardia. Next is diffuse esophageal spasm or distal esophageal spasm, as said in Chicago classification. Here again, nitrates and calcium channel blockers can be given to reduce the spasm. Botulinum toxin injection can be given in multiple sites of the esophagus to reduce the spasm. Then bougie dilatation, not a point dilatation, along the esophagus we have to dilate. So esophageal bougies are used for dilatation. And finally, esophagomyotomy. In diffuse esophageal spasm, we have to do a long segment esophageal myotomy. It is not Heller's cardiomyotomy, it is a long segment esophagomyotomy. There is a cut put in the esophagus body and the muscle is open. So there will be, even if it contracts, the contraction will be ineffective. So that is regarding the management of diffuse esophageal spasm. Now comes the Nutcracker Esophagus. It is also called jackhammer esophagus in the newer classification. So there will be odynophagia due to the increased peristaltic wave, increased amplitude of the peristaltic wave. So what will we do? The management is basically medical. Nitrates, calcium channel blockers are given in Nutcracker esophagus, Nutcracker esophagus. Now comes the hypertensive lower esophageal sphincter. The esophageal pressure is there. Lower esophageal sphincter pressure is more, but there is no normal peristalsis in the esophageal body. It is also called Achalasia Cardia in evolution. We have already said that after some times these patients will go in for a proper Achalasia Cardia. So the treatment is similar to Achalasia Cardia. We can do a nitrates Botox injection in the lower esophageal sphincter since it is not relaxing. There's cardiomyotomy or balloon dilatation and disruption of the lower esophageal sphincter. This is the management of hypertensive lower esophageal sphincter. Then the fifth one is ineffective esophageal motility. Ineffective esophageal motility disorder can be a primary motility disorder, but it can also be a segmental motility disorder, secondary motility disorder, like fragmented peristalsis or a ineffective peristalsis. So always, if you find an ineffective esophageal motility in a manometry, always look for an underlying disorder. Always look for a cause which is a systemic cause which is precipitating ineffective esophageal motility disorder like scleroderma, GRD, etc. And the treatment of the ineffective esophageal motility disorder should be tailored according to the findings in the manometry. So in brief, we have discussed about primary and secondary motility disorders of the esophagus, how the esophageal motility disorders clinical presentation, and we have learned about the different investigations and how to approach the esophageal motility disorders through these different investigations, and how the manometry has advances in manometry has changed the esophageal motility disorders, how the classification has been changed, how the outlook of esophageal motility disorders has changed by the improvement of manometry, and how to understand the curves and the diagram. And finally, we have discussed the treatment of esophageal motility disorders. With that, let me conclude. Thank you.